Thank you, Susan. And thank you, everyone, including Brian and all of you for inviting me to speak today. My topic is hematocrit or red cell recovery in autotransfusion, which is more important. And I would venture a guess that many people in the audience grew up the way I did, if you will. Yes. You can't hear me? Can you hear me all right?
We can hear you, but your presentation is not up. Okay.
It's not?
Go to share.
Share screen. It's a green button at the bottom.
Got it? Okay. Okay. There's a bit of a delay, isn't there? Okay. So what is optimal hematocrit for cell salvage? We expect higher hematocrit values in cell salvage devices with today's machines, and they are higher than they were historically with the older machines. We do expect a range between 40 and 70% on the outlet hematocrit, but is that higher hematocrit achieved at the expense of sacrificed red cells? So there are many variables, 5 in particular, that determine hematocrit in these devices. We do expect lower hematocrits in orthopedic procedures, for instance, than we do in cardiac procedures. The outlet hematocrit is dependent as well on the inlet hematocrit. So the lower the inlet hematocrit, the higher the outlet hematocrit will be, because it's been affected by the processing parameters such as the fill speed and the time that it takes to fill the bowl. And obviously, if there's more hemolysis than expected, the outlet hematocrit will be lower. So does a higher hematocrit actually equal better quality? So at one time, especially at the very beginning of autotransfusion, the only point of care measure of quality was hematocrit. So Waters stated in 2005 that hematocrit should no longer be used as the primary indicator of quality of the product. In 2003, prior to that, Cyril Sarek stated that a lower hematocrit is clinically insignificant as long as you are retrieving most of the red cells.
Hey, Susan?
The extra does, LivaNova Extra does have a wash quality sensor and hematocrit indicator that do help us determine a broad spectrum hematocrit on the product and also wash quality.
Hey, Susan?
Yes.
Hey, do you have a background noise? I think, are you on another program in the back? Maybe your YouTube is on?
We hear an echo, like you might have the live webcast open at the same time. Like
I might. Let me see. Yeah, and I've been hearing it all day too with all the other speakers.
It's probably because you have your web browser open. I would just close that web browser and entirely, and then the live webcast won't be playing at the same time. If you just entirely close all your web browser windows, that'll probably take care of it.
Let's see what I can do, guys. I know I've been hearing it too all day.
It's because you're in Zoom, but then probably also have the webcast open. I think.
Sorry, folks. I think everything's closed now.
Okay.
See,
we'll let you get back to it. Yeah, just hit start again.
Let's see. Well, how about now?
There you go.
Better? Okay. Sorry about that.
No worries.
So although hematocrit and red cell concentration in the centrifuge bowl does affect contaminant removal, that threshold is really much lower than we once believed. And as you notice, that's from a Tremaine article way back in 2001. So hematocrit should only be used as an indirect indication of quality, not as the end-all and be-all. So substances that could be harmful to the patient should be tested for percent removal. and that was suggested by Waters in 2005, but that certainly was not the first time. The AABB suggests that this removal rate should exceed 90 to 95%. Potassium and free hemoglobin are poor markers as they're generated during the collection and suctioning process. So a surrogate marker should be chosen that reflects a good coefficiency ratio to the substance that we're looking at removing. An older Mayo Clinic study suggested that we use a protein, specifically albumin. And this is a graph from that study. And if we just look, they've done pre and post. So pre's are in purple, posts are in orange. Processing efficiency or percent removal is demonstrated in yellow. So albumin, heparin, plasma-free hemoglobin, and potassium were all tested. And as you can see, albumin is removed at 99.2, heparin slightly greater, whereas plasma-free hemoglobin and potassium can be expected to be removed at a slightly lower level. So this is just the calculation to get to the percent removal. So the lab gives us a concentration value. In order to get to mass, we take concentration times volume, which is the volume in the bowl, divided by 1 minus the hematocrit. And then we take the mass in minus the mass out, divide by mass in, and that gives us percent removal or processing efficiency. So under normal physiologic conditions, systemic hematocrits in people is maintained at somewhere around 35 to 45 in women, 39 to 50 in men, and of course, those are ballparks. So too low a hematocrit may result in inadequate removal of contaminants when we talk about a salvaged product. If the hematocrit is too high, so much higher than 50%, let's say in men, or 45 in women, the product becomes too viscous to reach the microvessels, and anesthesia often dilutes it before they reinfuse it. So the optimal hematocrit also is probably not the same for all people. Athletes and healthy individuals who are younger can sustain lower hematocrits than the elderly or the very ill. So something else to consider is that with increasing hematocrit, the oxygen content of the blood increases in a linear fashion. But at the same time, the viscosity of the blood increases exponentially. This increases resistance to flow and decreases actual blood flow to the capillaries. So O2 transport capacity of the circulatory system increases to an optimum hematocrit value and then declines beyond it. So there's also something called diffusional oxygen loss, which refers specifically to the oxygen that is not able to be delivered to the microcirculation. In 2017, Zimmerman did a physical model that showed transfusion-associated increases in blood viscosity, which resulted in lower blood flow to the capillary beds and increased diffusional oxygen loss prior to the blood arriving at the nutritional circulation level. So an overlooked variable regarding quality in cell salvage, I would suggest to you, is the red cell recovery rate. So what is that exactly and how is it calculated? This is from Cyril Sarek, again in 2005. So in order to come to a red cell recovery number, you take the volume in the holding bag times the hematocrit in the holding bag, divide by the volume in the reservoir, times hematocrit in the reservoir, and multiply by 100%. So from an earlier article, Sarek also observed by testing 5 machines and doing a side-by-side comparison that all machines but one achieved a 50 to 55% hematocrit. The machine with the lowest was at 45%, but also had the highest recovery rate. So this suggests that perhaps that higher hematocrit, again, is achieved by sacrificing actual red cell recovery. So the lower hematocrit is really clinically insignificant as long as you retrieve as many red cells as you possibly can. So another major finding from that article has really been ignored and has resulted in us continuing to fixate on hematocrit as being the most important quality marker. So Waters in 2002 presented a case study with the assumption that a patient was a 70 kilogram patient with a starting hematocrit of 45% and a transfusion trigger of 21% was what he chose to use. What he determined was if the red cell recovery rate is 60%, the patient will need to be transfused at 9,600 mils of blood loss. If we can increase that recovery rate by a mere 10% to 70%, the patient can sustain a significantly higher blood loss of nearly 14,000 mLs. So that's a difference of 17% more blood loss that can occur before the patient needs to be transfused. And this is a graph basically showing that, and I can't see all that graph, so I'm hoping that you guys can. So red cell recovery has a greater impact on the need for allogeneic transfusion than the actual hematocrit of the end product. So how do we maximize red cell recovery rate? There are techniques, obviously, that we can employ to achieve as much red cell recovery as we can. So in order to optimize that red cell return, we can be rinsing sponges and rinsing the reservoir, sometimes creating an even fuller bowl. We can minimize shear stress and hemolysis by using a larger size filter in the reservoir. And of course, we want to properly anticoagulate the blood to minimize clotting and reservoir holdup. Excuse me. So I had just said that we needed a larger bore filter on the reservoir. That filter size really does have an impact. So even AABB says it's wise to avoid the smaller filters because small amounts of residual clot and debris can prevent blood flow through the filter. So we have red cells trapped inside of the sock, inside the red cell filter. It's also recommended to mechanically agitate the reservoir while flushing with normal saline to dislodge residual red cells. And if you're given a choice of a 40 micron or a 120 micron filter, always choose the 120 micron. We can rinse gauze pads and sponges by placing them in a plastic bin of normal saline, gently squeezing them out, and then aspirating that rinse solution of normal saline into the collection reservoir. These fully soaked sponges may contain up to 100 mils of blood, and about 75% of that is retrievable. So this has been reported to increase red cell yield by 28 to 31%. That's a lot of red cells that we can be getting from sponges. So the efficiency of the cell salvage is a function of several variables. The patient's starting hematocrit, their blood volume, the size of the bowl that you choose, and the efficiency of the actual recovery process. So achieving a higher red cell recovery can reduce the incidence of transfusion and result in substantial cost savings to the hospital. And keep in mind, again, a lower hematocrit, for example, 45% versus 55 or 60%, is clinically insignificant as long as you are retrieving most of the red cells. Keeping in mind, in the spirit of what we at one time called blood conservation, every cell is sacred. Thank you. I'll take any questions that you might have.